over now are going to be ones that you'll dissect on Wednesday when we do posterior abdominal wall. All right, so coming directly off the aorta and running up the inferior surface of the diaphragm, we have the inferior phrenics. Coming from the aorta to the suprarenal gland is one called the middle suprarenal. Running over to either of the kidneys, we have renal arteries. Then we'll have an artery that comes from pretty high up and just sort of disappears off the page, and that will be a gonadal artery, either testicular or ovarian. We also need to get blood to the abdominal walls, so we have a series of lumbar arteries. These are basically the same as our intercostal arteries higher up, except we no longer have ribs for them to run between. If we look closer at the kidneys, we have a couple of other named branches. So we have our right and left renal arteries running directly into the kidneys. And then each of the suprarenal glands is going to have 3 separate arteries or groups of arteries going to it. So coming off of our inferior phrenic and coming to the superior part of the suprarenal, we have the superior suprarenals. The middle suprarenal I already mentioned is going to come directly off the aorta. And there's an inferior suprarenal as well, and that one's going to come off the renal artery. So we have 3 separate arteries going to each suprarenal gland. Okay, now on to veins. So we've mentioned veins a few times, but there's a fundamental dichotomy between veins in the abdomen. So we have 2 systems sort of intermingling here. We have the systemic system or the caval system. Caval because this has to do with the vena cava. And then we have the hepatic portal system. All right, so systemic system first. Blood is going to be pumped through the hepatic portal vein into the liver, and then after it passes through the liver, it gets drained back into the inferior vena cava through a number of veins called hepatic veins. So you'll see these today when we mobilize the liver and look at it from above. We also have inferior phrenic veins running along the inferior surface of the diaphragm. Right and left renal veins running to the right and left kidneys. We have right and left suprarenal veins, and right and left gonadal veins. If you look a little bit more closely at the venous drainage of the kidneys, you can see that this is going to be pretty asymmetric. So our right and left renal veins are not here created equal. The left has a much farther distance to go, and inferior vena cava sits over on the right side of the abdomen. Because it sits over on the right side, our little tributaries of these different structures are going to drain into different places. So on the right side, everything's going to drain directly into the inferior vena cava. So our right suprarenal vein just drains straight across into the IVC. On the left side, that's a really far distance to go, and there's this giant celiac trunk in the way. So on the left side, the left suprarenal is just going to drain straight down into the left renal. And the same is true for our right and left gonadal veins. On the left side, it will drain into the left renal. On the right side, it will drain directly into the inferior vena cava. All right, now if you look at the vessels all together, so remember our venous drainage is going to be asymmetric on the 2 sides as we just mentioned. Also keep in mind that the number of arteries and veins going to the suprarenal glands are not the same. So we have 3 arteries going to the suprarenal veins, suprarenal glands, superior, middle, and inferior suprarenal arteries, and we only have 1 suprarenal vein. So 3 arteries, 1 vein. All right, so some other veins in the posterior abdominal wall that we'll want to keep in mind. So remember our zygous and hemiazygous vein interact with the abdominal drainage. Here we have our right and left subcostal veins. And sort of the continuation of the azygous and hemiazygous system in the lumbar region are the right and left ascending lumbar veins. Draining the body wall, we're going to have right and left lumbar veins, and these are going to drain into those right and left ascending lumbars, and they'll also send occasional branches across to the inferior vena cava. And then put it all together. I'm not going to go over it all again, but this is sort of a one-stop review session for you when you're reviewing venous drainage of the abdomen. All right, so this is the caval system or the systemic system. The rest of the structures that we've talked about for the abdomen are all going to be drained by the portal system, or the hepatic portal system, which is named for the hepatic portal vein, which you guys all dissected on Wednesday. So our two main veins that will come together to form the hepatic portal vein are the splenic vein and the superior mesenteric vein. So after the juncture between those two is when we start calling it the hepatic portal vein. The inferior mesenteric vein is usually shown draining into the splenic vein, but there's a lot of variability here. Sometimes it will drain over into the superior mesenteric, and it can really go anywhere in here. So sometimes it will go right at the juncture of the two. If you look at this in a little more detail. A lot of the named veins for these areas are going to follow the same names as the arteries, and at least once we get into the mesenterics, they're going to follow the same pathway. But up here, the left gastric is going to be a vein that's going to drain the lesser curvature of the stomach, and it will go right into the hepatic portal vein. There is no celiac trunk version of a vein. So our right and left gastrics will both drain directly into the hepatic portal vein. Here's our superior mesenteric and splenic veins. And then now as we follow along the superior mesenteric vein, we're going to have a number of named branches that are going to mirror what we saw with the arteries. So draining the transverse colon, we'll have a middle colic vein. We have a number of intestinal veins draining the small intestine. We have a right colic and ileocolic veins draining the ascending colon and cecum region. Now if we remove the small intestines, then we can see the inferior mesenteric a little bit better. You can see here it's shown draining up into the splenic, but remember it can cut across and drain into the superior mesenteric. Here's our left colic vein, which is up quite a bit higher. And then our sigmoidal veins and our superior rectal vein. So you'll notice that the veins we saw in the superior mesenteric tend to follow right along with the arteries. The same isn't necessarily true for the vein because our inferior mesenteric vein is often going off in a very different direction than the artery. So the artery is coming sort of straight across from the aorta. The vein is usually running straight up to get to our splenic vein. So your left colic vein may be located a lot higher than your left colic artery. Okay, a little bit of a comparison here. So the primary vein for the hepatic portal system is, unsurprisingly, the hepatic portal vein. And our primary vein for the caval system is the inferior vena cava, at least in the abdomen. The hepatic portal system will be in charge of draining the gut and all of its outgrowths, while the systemic system will drain everything else. And the main reason for this is we want all of our venous drainage from the gut is going to be need to be filtered before it gets added back into the systemic circulation. So all of these veins that are interacting with gut structures send their blood to be filtered by the liver before it gets put back into the systemic circulation. So these are two separate systems, but they do interact with one another in a few places. In a perfectly healthy person, these are totally negligible, but if you have a problem with your portal system or with your caval system, these interaction spaces become important. So normally we talk about these when in instances of blockage of the hepatic portal vein, which happens a lot of times when you have liver disease. Venous drainage won't be able to be pushed through the liver, but we're still pumping blood through here. So that venous blood has to get out of the portal system somehow. And so it'll get forced towards areas where it has anastomoses with small systemic veins. So our first place that this happens is the gastroesophageal anastomoses. And this will be between the gastric branch of the esophageal branch of the left gastric vein with the esophageal veins that we saw in the thorax. We have an anastomosis in the anorectal region between our superior rectal and the middle and inferior rectal veins. There's one near the umbilicus called the paraumbilical, and this will be between the paraumbilical veins, which will run through that round ligament of the liver. And they have anastomoses with superficial vessels around the umbilicus, so things like superficial epigastrics. And our last ones are called the retroperitoneal, and these can occur anywhere where we have secondarily retroperitoneal gut structures. So in this case, we have the descending colon will be pressed up against the abdominal wall, so there will be lumbar veins there, and they can anastomose with these left colon veins. All right, just a little more detail of the two. So when you have problems with your portal system, or what's called portal hypertension, we start forcing this blood in the wrong direction in the portal system to get into the cable system. And where this happens along these gastroesophageal anastomoses, these vessels are all very small, and they're not meant to control a large volume of blood. So when we start pushing blood into them, a lot of times these vessels get distended and form what we call varices. So we get these really engorged veins in here, and since they're stretched, they can rupture really easily, causing internal bleeding. Similar thing for the anorectal, so we can get blood flowing through the superior rectal veins into the inferior and middle rectal veins, and this is the cause of rectal varices or internal hemorrhoids. And when we get it in the paraumbilical region, this forms something that we call caput medusae, which is these really engorged sort of squiggly veins sticking out around the umbilicus. So does anyone know what caput medusae would mean? Latin scholars in here? Yeah, so it means Medusa's head. Or Medusa had all the snakes in the head, so apparently this looks like you've got a bunch of snakes squiggling out of your belly here. Okay, so a little bit more on peritoneum and mesenteries. So Dr. Fliegel gave you a demonstration of how we get the gut structures surrounded by peritoneum. And we end up with a layer of peritoneum on the visceral structures called our visceral peritoneum. We'll have a parietal layer of peritoneum around the abdominal cavity. The space between them is the peritoneal cavity, which is just a potential space and should contain nothing but serous fluid. But we need to get vasculature and nerves to these visceral structures. And in order to do that, they're going to pass through these double folds of peritoneum called mesenteries, which are going to suspend the abdominal organs either from the abdominal walls or from adjacent organs. So we got into this a little bit in lab on Friday. There are a lot of different mesenteries, and there are a lot of named mesenteries. The greater and lesser omentum we went over last week. I'm not going to go through all of these, but most of them are called ligaments, and the first part of the name usually tells you what they connect. So gastrosplenic will be a connection between the stomach and the spleen. So if you learn the various words that are related to the organs, so anything that says gastro will be related to the stomach, anything that says phrenic will be related to the diaphragm, you should be able to put together what two structures are being connected here. Yeah?
Do you have to memorize this?
Do you have to memorize it?
Yeah.
No? But you should know them. I just explained how you should know them.
Like, do we have to identify these?
Like, you won't be asked to give a list of all of the mesenteries in the abdomen or something like that.
Okay.
But you should be able to say what is the mesentery that connects this structure to that structure or something like that.
Okay, in lab, right?
Or in lecture.
Okay.
This is lecture. Most of these in lab, we're going to destroy a lot of them. As we pull the abdominal viscera out of the gut cavity, most of these are going to be destroyed. So this is actually more of a lecture question than it is a lab question. All right, so we'll go through a few of these, ones that we're familiar with from Friday. We have our hepatogastric ligament, which will connect the liver to the stomach, and the hepatoduodenal ligament, which connects the liver to the duodenum. And these two ligaments combined are called musculomental. We have another named ligament here that's going to connect the stomach to the transverse colon, and this forms part of the greater omentum, and this is the gastrocolic ligament. And then we have this sort of free hanging sheet down there that's just called the apron. If we lift up the stomach a little bit, we can see some of its connections with organs on the posterior wall. So here's the gastrophrenic ligament, which is going to connect the stomach to the parietal peritoneum on the surface of the diaphragm. We have a gastrosplenic ligament connecting it to the spleen. And if we lift up this part, we can also see the connection of the transverse colon with the posterior abdominal wall called the transverse mesocolon. If we get rid of all of this stuff, we can see our gastrophrenic ligament a little bit better. And we can also see another very short ligament that's going to connect our left colic flexure with the peritoneum covering the diaphragm. And this is the phrenicocholic ligament. All right, continuing on with mesenteries. Here's our apron has been lifted up. Now we can see that transverse mesocolon from below. The mesentery that connects the small intestine to the posterior abdominal wall is just referred to as the mesentery or the mesentery proper. The cecum, remember, is mesenteric, so that will be mesocecum. And the sigmoid colon is also mesenteric, and that'll be the sigmoid mesocolon. All right, so now we'll go over peritoneal relationships. So some of this will be a review from what Dr. Flegel talked about last time. So determining what is mesenteric versus primarily or secondarily retroperitoneal. And then we'll finish this off by going into an explanation of why certain structures end up in different parts of the abdomen. All right, so structures in the abdomen or viscera in the abdomen that are suspended by a mesentery are referred to as mesenteric or